In this talk, I'll go through some of the evidence around COVID-19, particularly for intensive care clinicians, now that we're about 6 months into the pandemic, and some of the things that we perhaps still don't know or are controversial. So firstly, just a quick note on digital object identifiers. I'll use these throughout the talk to refer to articles because many of these are not yet published in a sort of issue and volume as would normally be done. The DOI you can use to turn into a URL quite quickly by adding https://doi.org/ to the front of the numbers, and that will take you directly to the article. If you read nothing else, 3 things to look at now would be the COVID-19evidence.net.au website. This is a set of living guidelines developed by the National COVID-19 Clinical Evidence Task Force and is updated regularly as new evidence is published. Highly recommended, and most of the treatment decisions that Australian intensive care units make would be in line with these guidelines, I imagine. The second thing that to look at would be this review article published in JAMA. It looks at the background, the pathophysiology, mechanisms of transmission and prevention, diagnosis and also treatment of COVID-19 current to the end of June. It's a very nice article, well written and highly recommended, and authored by one of the Alfred's infectious diseases clinicians, Professor Alan Cheng. The third thing to look at is this report published by ANZIX and Sprint-Sari, which gives you an idea of the local experience to the end of March. This includes patients who are suspected or confirmed to have COVID-19 from the ANZIX data, and then also patients, a little more detail on a subset of patients who are confirmed to have COVID-19 from the Sprint-Sari data. And this is available online. So for the rest of the talk, we'll look at a few things. Part 1 is to look at some of the things we know that perhaps we didn't know at the start of the pandemic and some of the ongoing controversies. And in the second part of the talk, we'll look at some of the major treatments. So the first thing I think we know now is that mild and asymptomatic cases are more common than we thought. These seem to be a significant component in disease transmission, particularly in contexts like nursing homes and on some of the cruise ships. And this has relevance for healthcare workers because it means that we need to be vigilant in who we test for the disease. The second thing that we know is that simple measures like masks, physical distancing and eye protection do seem to be effective at preventing transmission of the illness. And this particular paper is from the Lancet and performed a meta-analysis and systematic review of these measures and has generated changes in public policy both in Australia and elsewhere to incorporate the use of masks. The third thing we've found is that thrombovascular pathology, including venous thromboembolism, but also microvascular thrombosis, is important in patients who are critically unwell and may play a large part in the development of severe COVID-19. For patients who are critically unwell in ICU, standard venous thromboembolism prophylaxis may not be enough. And there is a high rate of PE and VTE in patients in ICU, in some cohorts up to 40 to 50%. So the national guidelines now recommend considering the use of essentially a double dose of prophylaxis. So this would be equivalent to 40 milligrams twice a day of enoxaparin for patients who are critically unwell. And the other thing we know, which seems trivial now but did cause some angst at the start of the pandemic, was that ACE inhibitors and angiotensin receptor blockers, although they work in the same pathway as the ACE2 enzyme, which is implicated in the disease transmission in the way that the virus enters the cells, these seem to be quite clearly not associated with worse disease or increased risk of contracting the virus. And so these are considered safe to continue, and in fact there are well recognised harms with abruptly stopping these drugs in patients who need them. But there are still several things that we are not yet sure about. So whether children are different remains debated. We know that children seem to come to the attention of healthcare less often, so this would imply that they're either less likely to develop the virus, or if they do contract the illness, are less likely to become unwell. But we do know that children can still become critically unwell, and there's been a lot of talk around the syndrome that they develop and whether this is the same as COVID-19 in adults or not. So this article in NEJM reports on a cohort of critically unwell patients in the US, critically unwell children, I should say, and some of the characteristics of their illness. The second thing is the nature of the respiratory failure that patients develop has been compared to ARDS, and what we don't really know is whether it's the same or behaves in the same way as other forms of ARDS. And I suspect that given that ARDS is itself quite a heterogeneous syndrome incorporating many underlying pathologies, that it won't be the same as many as some other types of ARDS. Interest in this was prompted by a opinion piece by Gattinoni in April, where he described patients with low oxygen levels but high pulmonary compliance, and argued that these were different from other typical ARDS patients. This has generated some interest, and there have been several cohort studies looking at patients. A recent review in Lancet Respiratory Medicine goes through some of the evidence around this and explains why this might be important for clinicians. The big questions here really are whether we should treat patients who are hypoxemic but still have preserved pulmonary compliance differently, particularly whether we should delay intubating them or not, as some have suggested. And I don't think there's a clear answer still around this question. Similarly, with patients who are hypoxic, people have tried awake-prone ventilation with the hope that this may prevent them from being intubated or admitted to intensive care. There have been several cohorts reported of patients where this has been tried. The general theme is that it doesn't work for everybody. There's about half of patients who don't tolerate being prone for a length of time, such as 3 hours. And of these patients who do tolerate it, only about a half of those, in fact, will respond or have a sustained response in their oxygenation. What we don't know, though, is that whether improving your oxygenation actually translates to avoiding intubation or avoiding intensive care. And I think there's further studies that need to be performed before we can be clear in recommending a systematic program of proning awake patients in the same way that we have some guidance around when to use prone ventilation for intubated patients and when not to. So some of the other things, well, look, it's well recognised that the virus can spread by droplet. However, what's uncertain is whether aerosol transmission is significant. And the early stance from the WHO has been that, like other coronaviruses, SARS-CoV-2 is a droplet transmitted disease, and that aerosol transmission is not a significant component. However, more recently, there's been an open letter published by a couple of clinicians, including one from Australia, and signed or endorsed by a large number of clinicians worldwide, making the case for aerosol transmission. I think it's fair to say that there's some evidence that aerosol transmission can occur. The real question is whether or not this is a significant mode of transmission for the virus, because this will inform public policy and healthcare policy and has implications for the PPE that staff need to use and so on. There has recently also been a review article published which provides the counterpoint to some of these arguments, and I'll link to that. The other question is around immunity and whether you can get it twice, for example, in a short space of time, as this case report suggested, and whether in patients who don't develop a serological response, whether there's still some degree of immunity afforded by T cells, and whether T cells, in fact, play a greater role in immunity than we thought. So I imagine that this particular question will be an area of interest in research over the coming months. So at this point, we'll move on to treatments. There have been several treatments trialled and several large studies which are looking at a variety of treatments under the same trial umbrella. So these are generally known as sort of multi-platform trials, and some of them have an adaptive design, which means that they are able to take up or drop treatment regimes as evidence strengthens that they're either harmful or beneficial or of no use. REMAP-CAP is the one that we've been involved with locally. Recovery is a large trial in the UK, which has already published several results and has the advantage that it's been able to coordinate under the National Health Service. The Solidarity trial, led by the WHO, is of a similar nature, and Discovery in Europe. And so all of these are testing many of the same therapies. Somewhat surprisingly, hydroxychloroquine emerged as an early contender, and this was based, I think, originally on some in vitro evidence suggesting that during the 2003 SARS pandemic, that hydroxychloroquine was, or epidemic was associated with reduced viral replication. So in March, Gautret in France and his group looked at the use of hydroxychloroquine and azithromycin for critically unwell patients. And the study purported to claim that there was reduced mortality as well as viral expression for patients receiving particularly the combination of these two drugs. Now, this trial has subsequently been quite heavily criticised. We've performed our own, or written our own analysis in Intensive blog, which you can review. But it was of interest enough that it generated a lot of further research and came out at the same time that many of the trial groups were developing their trial protocols, so it was incorporated into most of these. So what we know now is that from observational data, there seems to be no benefit of hydroxychloroquine. It's been looked in several large cohorts of several thousand patients, and when you control for other covariates such as age and severity of disease, the use of hydroxychloroquine seems not to be beneficial. We also know that in higher doses, chloroquine was associated with increased mortality in critically unwell patients in Brazil. And this was the start of some of the concern, I guess, around hydroxychloroquine. And then finally, the recovery trial, which has published some of its results in an early form, has suggested that in a well-designed randomized controlled trial, hydroxychloroquine is not beneficial. And we're also waiting on the results from some of the other trials, such as REMAP-CAP and Solidarity, which have also looked at it. So recovery, which as I said is a multi-platform trial looking at several therapies, has released a preprint of their hydroxychloroquine results. So this is not yet peer-reviewed, but in their trial, they looked at a fairly high loading dose of hydroxychloroquine within the first 24 hours, and then twice a day, 400 milligrams for a total of 10 days. They have, at this stage, now achieved 98% follow-up to 28 days, which was their primary outcome time period. And they have stated that the results show no significant difference in the rate of death at 28 days with the use of hydroxychloroquine. However, they've also found in some of their secondary outcomes that there seems to be an increased length of stay with hydroxychloroquine. And in fact, in patients who are not intubated, they may have a greater progression to invasive ventilation. So this suggests that hydroxychloroquine is certainly not beneficial and probably harmful. And it was largely the results of this trial that resulted in other trial groups and treatment authorities in recommending against the use of hydroxychloroquine. Kaletra, which is leponavir-ritonavir, a combination antiretroviral therapy used originally for HIV, also emerged as an early contender because it also had some in vitro evidence from previous coronavirus epidemics that it may be beneficial in suppressing viral replication. A fairly early randomized controlled trial, though, came out in NEJM from China, which looked at patients receiving up to 2 weeks of Kaletra therapy. This was a fairly small study of about 200 patients and looked at the time to clinical improvement as measured on a scale ranging from essentially well with no respiratory support to severe disease on invasive ventilation or death. And they found that there was no difference in the time to clinical improvement with the use of Kaletra versus standard care. Now, there was also no difference in mortality, which is one of their secondary endpoints. And although this was a fairly small trial, no other larger trials have actually shown results that disagree with this finding. The recovery group have released early results about their Kaletra arm. They have not yet released the preprint, and so this is, or published it, more to the point. So this is all we really know, but they stated that in their trial, the use of leponavir-ritonavir was not associated with a reduction in mortality. However, the caveat to their study is that it included a low proportion of invasively ventilated patients because Kaletra, although it is available as a solution that can be given in the nasogastric, the tablets can't be crushed, and it may be that they had difficulty with obtaining supply. So this would have excluded many of the ventilated patients from its arm. Remdesivir is the really the antiviral that has shown some suggestion of benefit so far. Remdesivir is an antiviral developed originally for Ebola, which is another RNA virus. It's made by a company called Gilead, and they were quite quick to look to use it in COVID-19 and showed some in vitro evidence fairly early on that it was beneficial in suppressing viral replication. In May, there was a trial that came out in the Lancet from China, which randomized patients to receive remdesivir or not, and who were hospitalized with COVID-19. Now, they found no difference with mortality or time to clinical improvement in their trial, but the trial was terminated early because they, at that time, the number of new cases of COVID-19 was reducing in China, and they were unable to continue recruiting. Around the same time, the ACTT trial was released and published, and this was an NIH American funded trial of remdesivir, and I'll look at that trial specifically in a moment. There's also been a couple of other trials which have been referred to in the media and elsewhere. These are trials that were funded and designed largely by Gilead. The first, which is the trial company, the drug company. The first was a descriptive trial in NEJM, which essentially just presented a cohort of patients who were given early access to remdesivir and did not really give us very much useful information other than that that it was being used. And the other one was a trial looking at 5 versus 10 days of remdesivir therapy without any placebo or control group. And I won't dwell on that study because I don't think it actually adds very much useful information for clinicians, and we should focus on the placebo-controlled trial. So the placebo-controlled trial is the ACTT1 trial, which was, as I said, a US government-funded and run study of remdesivir or placebo for up to 10 days in patients hospitalized with COVID-19. So not necessarily critically unwell ICU patients. It is an intravenous drug, so it cannot be used in an outpatient setting. And the trial looked at, firstly, the time to clinical improvement, and secondly, mortality as endpoints. The trial results are described as preliminary because they essentially performed an interim analysis on the advice of the Data and Safety Monitoring Board and found that there was some benefit and decided to terminate the trial and unblind at that time. And this did coincide with the release of the results of the Lancet paper from China looking at remdesivir, which, as I said, failed to show any benefit. In the trial, they stratified patients by the degree of oxygen support that they were receiving, and overall they found that there was an improvement in the time to recovery for patients receiving remdesivir of about 4 days. When they looked at mortality, though, they found that there was a trend towards improvement in 14-day mortality, but that this at the interim analysis was not statistically significantly different. Also, they found that it mattered whether you received what sort of respiratory support you received. So patients who were requiring oxygen therapy seemed to benefit, but patients who were not requiring oxygen or were requiring more advanced support, such as high flow, non-invasive or invasive ventilation, did not show the same benefit. And you can see that these groups were smaller than the oxygen therapy group, but there was significant overlap in the confidence intervals. Because this is a preliminary analysis, there was still at that time about a third of patients yet to reach the 28-day endpoint, which was their original planned study outcome period. And so it may be that the final results do change the recommendation when they are published. There were some other concerns around the trial. There was issues perhaps with patient inclusion because it only included a very small number of the total cohort of COVID-19 patients at that time. There were issues with blinding and inadequate placebo, and there were some protocol changes which the trial authors state were made independently of Gilead, but Gilead was certainly still involved in the funding and also sort of, I guess, development of the trial. The major thing for ICU clinicians to be aware of, though, is that this is not an ICU patient cohort. It's predominantly people in hospital receiving oxygen, and the evidence that this trial gives us is that remdesivir may be helpful in patients who are in hospital on oxygen, but it doesn't give us clear evidence that it is beneficial for patients in intensive care requiring higher levels of respiratory support. And we have reviewed this article in detail on the intensive blog, which we'd encourage you to review separately. Dexamethasone was the sort of wild horse of COVID-19 so far. It was there all along. It's been long studied in ARDS, but with conflicting evidence, and was included in, steroids of some form were included in many of the multi-platform trials, including Recovery, which in June released early results to much sort of fanfare in the media, suggesting that dexamethasone was associated with a reduced mortality rate. This trial's now been published just this week in MEGM. The trial was a randomized trial comparing dexamethasone 6 milligrams IV or oral for 10 days versus standard of care in patients who were hospitalized with COVID-19. About 88% of these were PCR proven to have COVID-19, so some were not. And most of these were around a week or so into their disease. 24% required no respiratory support at randomization, 60% were on oxygen, and 16% were invasively ventilated. The primary outcome was the rate of mortality at 28 days. And at the time of their original results, released to the media, they had yet to achieve full follow-up for patients, but this is now the case. They did have to perform a post-hoc adjustment because they found that the standard care group were at baseline 1 year older than the dexamethasone group, which they attribute to the play of chance, but have adjusted for these. What they found was that dexamethasone was associated with a reduced rate of mortality amongst patients who were receiving oxygen or were receiving invasive mechanical support, but not in those who were on no oxygen therapy. When these groups were stratified, you can see that overall there was a rate ratio of 0.83 for death for all patients, but in the invasively ventilated group, this was as low as 0.64, with a confidence interval that was between 0.5 and 0.8 rather. And in patients with oxygen, requiring oxygen, this was 0.82 with a confidence interval that was between 0.7 and 0.9. So what this means is that from this evidence, dexamethasone seems to be associated with a reduced risk of mortality if you are receiving oxygen or invasively ventilated, and particularly if you're invasively ventilated. Now, much has been made about the no oxygen group. The first thing you can see is that it's a relatively small group compared to the other arms. It has a wider confidence interval, and although the point estimate is on the side favouring standard care, it does cross the midline, and so it is not possible to say whether dexamethasone is associated with harm or benefit. There's some concern, I guess, though, from these results, enough that many of the evidence groups have recommended that dexamethasone not be used in patients who do not sick enough to require oxygen. In some of the supplemental data, you can see that when they stratified for time since symptom onset, patients who were within 1 week did not benefit from dexamethasone, and these may be also the same patients who were not on oxygen, because as you can imagine, it would be patients who were more unwell, had probably had their disease for longer. It was also associated with a reduced rate of intubation if you were requiring oxygen but not yet intubated, and it was associated with a shortened length of stay. So my impression with dexamethasone is that it is a drug that is probably beneficial for patients with COVID-19 who are in intensive care or requiring oxygen, and would be recommended for most patients in that context. The final area of therapy that's been looked at is the immunotherapies, and there's several of these at various stages of development. So convalescent plasma has had a small randomized controlled trial published from China, which suggested that there was no benefit, although the study was probably underpowered for mortality, but was associated with a shortened time to viral clearance, which was interesting. I understand that in the US, convalescent plasma has been given to quite a few thousand patients, and it's essentially a therapy where you take the plasma of patients who've already recovered from COVID-19 and have developed an antibody response, and infuse it into other patients who are currently unwell who do not yet have antibodies, in the hope that it might generate an immune response or mitigate some of the injury that's occurring. Tocilizumab, which is an anti-IL-6 antibody, has been incorporated into some of the large trials, including REMAP-CAP and Recovery, but we're yet to see results from these. Anakinra, which is an anti-IL-1 antibody, has also been used in some of the trials, and interferon-1 beta and other things have been used. But none of these have shown high-quality evidence of benefit as yet, and many of the trials that have been published are quite heterogeneous in the way that they're conducted and are also combined with other therapies. So there was one trial that used interferon-1 beta but used it alongside Kaletra and other things. It's very difficult to untangle what any one therapy is contributing. So finally on vaccines. So 6 months in, we now have sort of 5 lead vaccine candidates that have been identified by the US amongst sort of 100 or more who are in various stages of production. These 5, 2 of them are messenger RNA vaccines. So this is a technology that uses messenger RNA. Once the virus has been gene sequenced, they're able to then sort of recombinate sort of RNA and incorporate that into a vaccine. That's then able to inoculate the cell and then be translated and express a target protein. So quite an interesting method. There's another method which uses viral vectors. So these are benign viruses that have some of the SARS-CoV-2 genetic material incorporated into them, infect a cell without causing significant disease, but allow some translation and protein synthesis, which then generates an antibody response. So the Moderna vaccine is probably the furthest ahead. It's just published its phase 1 results. It's probably wrapping up its phase 2 trials and is about to start its phase 3. And some of the other trials are in various stages of development. Locally, there's also some vaccine candidates. So Monash have a messenger RNA vaccine that they've announced, which I believe is still in preclinical phase. And the University of Queensland and the Commonwealth Serum Laboratories have partnered to develop a vaccine using a different technology called a molecular clamp. What this, I understand, is a way of stabilizing a surface protein that is antigenic but unstable when it's not expressed on a viral membrane. So by sort of clamping, stabilizing this protein, it's able to maintain its antigenic properties and then is able to be suitable for use in a vaccine. So I think they're about to start their phase 1 trials. And this is useful because although we're probably still 6 or 12 months at least away from having a viable vaccine candidate that can be produced on a mass scale, there's still uncertainty how we would produce enough vaccine for a world supply. And so it may be that local countries have to rely on their own vaccine programs to a degree, at least in the early phases, before they're able to access and vaccinate a large proportion of their population. So these are the major developments in the last 6 months. In summary, a few things we knew now that we didn't know at the outset, some ongoing controversies, and really with regard to treatments, still not many that have good evidence behind them, other than remdesivir, which has some evidence for patients, particularly who are not in an intensive care setting, and dexamethasone, which has shown the greatest benefits so far in reducing mortality, but still worth remembering that two-thirds of invasively ventilated, failed to prevent two-thirds of deaths of those invasively ventilated patients, such as intensive care. So still not a cure by any means. Thank you for listening.